Please join me in welcoming Dr. Schumann.
Thank you. Thank you very much. It's great to be here. I was delighted with the invitation and just very happy to make several of your acquaintances and really touched by the alumni event yesterday, which was, I guess, new and really just fabulous to be a part of it. And it's always great to be back in Boston, especially in light of what happened about a month ago. So yeah, the title is sort of a mouthful, and Sandy invited me and said, well, what are you going to talk about? So we came up, we batted this around for a little while, but these are some of the themes that I write about and that I think about as a program director in internal medicine. So the talk is dedicated actually to my Uncle Ron, who died on Friday, and the reason I have to motor on out of here. I'm going to tell you about my disclosures and biases. So as you heard, I'm a blogger, but I'm an ad-free blogger. It's amazing how, I guess, as you get more well-read, people will solicit you and try to put content and crap on your blog and pay you for it. But I feel very strongly that it's that might be my phone or something, that my work remain ad-free. As mentioned too, I write. I've written for magazines, really online magazines. Actually, I had just very recently my first NPR blog post for Shots, which is their healthcare blog. It's an excellent blog and well edited. So that was very exciting for me personally. The public radio that I do is mostly local. It's in Tulsa, but it's been very rewarding. Actually, I do it all for free since I have a day job. And then as a consultant, the only disclosure is there's again related to my blog, there's a company called Twistle.com, which is really trying to revolutionize doctor-patient communication, something I believe in strongly, and so I've been consulting for them again. I haven't received anything. If it ever takes off, maybe I would, I guess, get some money for that, but no other kinds of conflicts of interest, and I've done legal work, just reviewed charts and things. My other biases are I'm in academia. As you heard, I'm an internal medicine residency program director, so I come at you with that. I mean, talking to an audience of people in residency education, I can't think of a better audience for some of the messages. My other bias is primary care. As you heard, I believe strongly in the longitudinal relationships with patients that primary care provides, and you'll hear a little bit about that. And then, as you heard about the school that I now work at, I believe in community health and caring for the underserved. So just so you know where I'm coming from. So that red state right there in the middle is Oklahoma. And you might think, why on earth is a guy from Oklahoma here talking to you? And the answer is, well, I started here, I guess, and so I was one of you, and was involved in house staff negotiations, and I'm no longer on a coast. I'm right smack in the middle. I'm not on a coast. I'm not on an international border like I know CIR, SEIU programs are affiliated with. And just, in case you didn't know, I live in a very, very red state. One of 3 in 2012 where every single county voted for Romney, and in 2008, Oklahoma had the distinction of being the only state in the Union, including Alaska, that every county went for McCain. So why Oklahoma? So this gives you some example. This is from the Oklahoma State Fair. This is my usual lunch spot, actually. And these deep-fried Oreos are really, they're quite singular. So I don't know, red state, this kind of nutrition, I don't know if they're correlated or not. This is a busy slide, but basically just a placeholder to tell you that the leading health indicators in Oklahoma are exceptionally poor. So we rank about number 48. And the joke in Oklahoma is always, well, thank goodness for Mississippi, because Mississippi typically ranks worse than we do. But that's really not funny. But we're 48. And you can see that we are well above the national average in heart disease deaths, cancer deaths, on and on. We're way below the national average in vegetable consumption, no physical activity, or we're high in no physical activity, we're low in physical activity. which is, understandable. So that door was sort of closed to me, so I looked into other avenues, and so I got into hospital operations. And so one of the intractable problems for us was getting admitted patients from the ER to their hospital bed, something I'm sure you can identify with, regardless of your specialty. And so the chief medical officer sort of hired me as like a junior apprentice with the idea of grooming me for some kind of leadership role, maybe to be a chief medical officer someday. And I was really intrigued, and so the best part about it was I got a seat at the table. And I went from being kind of a workaday academic doctor who did a lot of teaching and clinical care to suddenly having this administrative role. And I took it very seriously. And so I thought as a patient, isn't it horrific how long patients are waiting in the emergency department? If I were a patient, or if it were my mother, my father, my brother, I'd want them, in their hospital room as quickly as possible. There's got to be a better way. And so when you analyze the problem, there's many, many moving parts, right? There's transportation, there's environmental services, has to clean the rooms, there's the whole kind of admitting infrastructure with admitting and billing and discharge and the computer stuff. That's an oversimplification, but it was hard. So what do you do? So I looked at what the other guys were doing, and I talked to other academic health centers, I talked to Vanderbilt, and I talked to Mass General, and it turned out they had really incredibly bright people working on this problem, and yet it was something that nobody seemed to be able to solve. So a friend of mine who was in business said, why are you calling these academic nonprofit health centers? He said, call the for-profits. They're the ones who are really motivated. They have a business case to want to improve customer satisfaction, as it were. And I thought, yeah, he's kind of right, actually. I mean, the whole idea of talking to for-profit hospitals seemed somewhat anathema to me. So I actually called the folks at HCA, the Hospital Corporation of America. They own 100, at the time, they owned 179 hospitals across the United States. And I wound up talking to their chief nursing officer, who was charged with tasked with dealing with this problem. And she couldn't have been nicer. I thought, I'm talking to for-profit people. They're going to guard all their industrial secrets. They're not going to share with me. And she said, in kind of a southern drawl, she was from Tennessee, she said, honey, if you can, if you figure anything out on this, please get back to me. We're looking to share. We're looking for best practices. We really want to solve this thing. So I dutifully compiled my report. I brought it to the committee, and people thought, wow, this guy really put in some work. He's ambitious. Maybe we should listen to him. Everyone kind of politely clapped, and the report went up on the shelf. And then, it was 2007, 2008, and then basically all hell broke loose. The economy tanked, and they forgot all about it because the hospital was suddenly hugely in the red, and they had to start cutting services. So it was sort of a leadership lesson in terms of being ambitious, being willing to jump in and roll up your sleeves and fill a need where a need is expressed. And then, of course, to realize, that doing the research alone isn't enough. You have to be willing to do the advocacy. You have to be willing to talk to people outside your comfort zone. And then, circumstances obviously can come beyond, I don't have to, what happened here in Boston or what happened with Superstorm Sandy, so circumstances can certainly conspire against you. So this was just kind of the outline. So it was all junked. My report was junked basically for money, meaning we had to cut budget. There was no way we could focus on these patient satisfaction priorities because what we had to do was focus on the bottom line. And if that isn't a message that you've already received in many shapes and forms, I would be kind of shocked talking to this audience. The University of Chicago had sort of a unique perspective on it. Their mission was really to preserve research. So as a classic academic medical center, they prioritize the triad, right? Research, clinical care, and teaching. But what I joke about them is that their priority is really research, then research, and then maybe clinical care, and at the very bottom, teaching. What shocked me about the reorganization that the hospital underwent in the financial crisis was just how vulnerable education was. That is, education was the lowest priority. They redistributed, they did this thing called bed geography, where our medicine services used to take every available bed, and they suddenly just said, we're not taking any new Medicaid patients. And they did things like that were really appalling, and us in the general internal medicine section, were so sort of downtrodden with our financials all the time. We were always told what losers we were, that basically there was nobody willing to stand up and say this is wrong. So you hear that all the time, no money, no mission. That is, if you don't attend to your hospital's bottom line or your academic medical center's bottom line, you can't deliver on your mission. And there is truth to that. And I talk about the brass ring of trying to maintain your ideals in a very difficult economic climate. So that leadership experience humbled me. I went from operations to focusing more specifically on the patient experience, because it won't surprise you that as a very prestigious research institution, the University of Chicago, even though it has a great reputation, actually has a very, very low Prestini, patient satisfaction type of situation. And so I tried again to make the business case to them, the language that they speak. And I said, if you look at our scores for doctor and nurse satisfaction, it's going to cause a financial hit. Again, I identified a need and I went to leadership and I said, I want to work on this problem because I'm a good guy. My patients like me. I think my other patients in the primary care group like our doctors. So why are we doing so badly as an institution? And so some people got the message, some people didn't. It was about 2 years away from HCAHPS going into full effect and value-based purchasing. So it got somewhat of a mixed response. But so that was when I started the blog. And I had this urge to sort of tell stories and to not dish dirt so much, but to really wrestle with some of the ethical and business issues. And so a friend of mine, a colleague of mine, a doctor who had already started his own blog from the angle of he's a practicing Buddhist physician, and so that's kind of his thing, is he's a Buddhist physician. Just actually had a book release that's doing very well. He sort of gave me advice. He said, start a blog. And I said, well, I think I'm going to do it anonymously. I'm going to sort of do it satirically and write about how crazy this place is. And he said, that's a terrible idea. Don't do that. He said, put your name on it. He said, stand up for what you believe in, identify yourself, and doing so makes you more responsible. It makes you more of a citizen. It gives you this idea of civil discourse. And lo and behold, like, my passion was really discovered, which was medical communication for lay audiences. So trying to take all this complex stuff we do. I mean, how many times have you had to explain to your loved ones or to your friends or to, oh wait, you're a resident? What's the difference between an intern and a resident? Or, what's an attending? Just even that stuff alone is hard to explain, let alone, what is value-based purchasing, or what is accountable care, or what is a patient-centered medical home, right? So this is a screenshot of my blog. This is what it looks like. Glass hospital, right? It's really, the theme is transparency. So people who live in glass houses should not throw stones. Similarly, people who live in glass hospitals. And the title really came from some of the architecture around the University of Chicago Medical Campus, and it's sort of catchy, and it's sort of caught on. The tagline is demystifying medicine 1 week at a time. So I'm really trying to demystify medicine and trying to get rid of jargon. And so that's become some of my passion. So civil discourse. This is a recent post about the news. You may have read this or seen this, that the physician-owned hospitals in the country, 287 specialty physician-owned hospitals, usually cardiology or orthopedic surgical hospitals, they got 9 out of the top 10 spots on the Medicare quality data list and 48 out of the top 100. So there's only 287 of these hospitals. The Affordable Care Act actually capped, you can't open a physician-owned hospital any longer without a special waiver. And so I sort of wrote it, this was kind of a satirical post. I said it wasn't really a surprise when these physician-owned hospitals get these very high quality marks. Of course they're going to rail against the Affordable Care Act and say, why can't we open more hospitals, or why can't groups of doctors open more hospitals? Look at how good we do in quality. Well, it's easy to do good quality if you're a single specialty, cherry-picking, well-insured patients doing kind of the same routinized procedures. Where does that leave the safety net hospitals, right, who take care of general medical problems and people with substance abuse issues and mental health issues? So I jokingly said, the means of production. I said, right, if we're going to have these physician-owned hospitals that do so well in quality, why don't we turn over our public hospitals, turn over the ownership of them to the doctors, but also the nurses and the environmental services folks and the food service workers? Because if you give us ownership put ownership at stake, suddenly our pride, instead of working for either the government entity or the county or the nonprofit player or the administrators in suits, we're suddenly working for ourselves. Wouldn't that be? So it's, a rhetorical flourish. This is another theme of the talk, is conformity, right? So when I was trying to solve that problem about ER wait times, what did I do? I said, well, what are the other guys doing, right? And so this is kind of the Mad Lib question. And this gets asked for anything, right? It gets asked in research dogma. It gets asked in clinical operations. It gets asked in patient satisfaction. And you can fill in the blank. But what is the other, the big hospital, the best hospital, the other academic center, the top rated, the nonprofit, what do those folks do? Fill in your blank. And that's how you'd sort of compare yourself, right? This is this conformity idea. And so some conformity is good, some isn't, right? So when I did my pediatrics rotation as a third-year medical student, it was sort of a big clerkship. There were maybe 24 students on it at a time or something, go figure. It was a big children's hospital. And the evaluation came back sort of like, there was pass and maybe high pass and honors, and I got just pass. And the comment was something like, John is a medical student. John wears a white coat. John has a stethoscope. I mean, it was a joke. It was like they didn't know who I was. It was just like I was another faceless medical student. I did nothing to distinguish myself in pediatrics. And so here I was, I had a white coat though. I could conform. I looked, I blended so well into the environment that, they didn't even know who I was. And then this is the best picture I could find. This doesn't really look like interviewees, but the joke here is you guys went and did your residency interviews, and pretty much the classic dark suit. Everyone comes in and they march in and they look pretty clean cut and come in for their interviews. And so there's this conformity in medicine is my point, right? So we conform. We want to know what the other guy is doing. We want to not stand out too much, because if we stand out or we rebel or we get aggravated, we are threatened or we're threatening. And so people want to either cut us down or put us in our place. So, and then unions are a form of conformity, but are arguably a good form of conformity, right? And so not all conformity is bad. I would say some obviously is problematic, but some is actually quite good. So less conforming, right? So I could have worn a white coat and had, 4 or 5 earrings. And I had trouble conforming. Like I hate wearing ties and I hate, that kind of thing. And a wise mentor said to me, you know what? It's really not about you. It's not about me. It's about the patient. So if you wear 6 earrings and, you don't really shave or trim your beard or something, you might alienate the patient. And you have to, that was really eye-opening for me. It was such a simple idea, but I realized, again, a certain type of conformity to conform to the expectation of the patient might not be such a bad thing. Because if your appearance is something that's going to, arguably be unprofessional, you may find it to be clean and professional, but the patient may find it off-putting. And really, who are we here for? I mean, ultimately, at the end of the day, isn't that what we're here for, is the patients? So these are my nonconformists. Now, does this guy look like a nonconformist? Bow tie wearing, kind of white-haired doctor, Howard McMahon from Ocilla, Georgia. This came from Parade magazine, my favorite medical journal. So he is the only doctor in this small town in Georgia where there are 21 miles to the nearest hospital. And this he's a former, I think he was in the Navy or something, and he's a military vet, and he feels obviously very strongly about being a country doctor. He feels this mission-driven purpose to provide care to his community. And he doesn't have a lot of resources in terms of being able to get specialty tests or have hospital backup. And he hasn't taken a vacation in 7 years. So he's kind of the ideal we hold out, right? But how realistic is that, right? So how many private practice solo docs are left? Well, I don't have to tell you, not many, right? So most doctors nowadays are employed. 2/3 are employees, right? So we've seen this dramatic shift just in the last decade. And many of you are thinking about jobs now and where you're going to go. And I mean, you guys are young and, I guess arguably millennial or Generation Y. And so, what are you thinking about? I know I'm not as old as I might seem, but I think very strongly. I've chosen to stay in academics largely for the reason that when I went to medical school and went through residency, nobody taught me about business. The idea of opening my own practice and renting space and buying malpractice, it's terrifying, right? Nobody teaches you about that stuff. It takes some tremendous courage. So while I think that the consolidation is going to continue to drive solo and small practices out of business, things like meaningful use, where we all have to essentially electronify our medical records, are huge overhead costs that have really changed the nature of the game. So this idea of this nonconformity, I think, is really outmoded, and yet we hold it up as a mythology. So sort of the last of a dying breed. And so in many ways, I think non-union shops or non-union physicians really might even be the last of a dying breed too, because I was thinking about this and preparing for the talk, and I realized so many physicians are now employed, and particularly in this new and rapidly growing field, hospitalists. I run a residency program. I have 15 graduates this year. 14 of them are going to become hospitalists. And part of me is disappointed in that, because there's this incredible self-referential thing in medicine, which is we want the people we like to do what we do because it validates us and it validates them. There's a connection made. And so I'm a primary care doctor. I identify very strongly with that. And so when I see graduates or residents that I really like, I think, I want them to do what I do because I want them to join my practice or be part of the team. And so I get it though. Like when you're coming out and the hospital job is offering you sometimes 25 or 50% more dollars and you get a 7-day on, 7-day off schedule, I'd make the same decision. I have loans to pay. I have a family. I got this work-life balance thing. I get it. It makes a lot of sense. And the problem I see, though, is that hospitalists are so interchangeable. And people have been saying this for a decade, mind you. I mean, the hospital thing's been around basically going on like 17, 18 years since Wachter coined the term hospitalist. But I recognize it as an opportunity for collectivization. I think that hospitalists are employees, And right now are sort of the halcyon days of being a hospitalist. The pay is good, the conditions are good. It's only going to be a matter of time as more people get into the system where you're going to see the squeeze on hospitalists. Just like nurses unions have fought for lower nurse-to-patient ratios, hospitalists are going to be fighting the same battles. And so I see that as a potential area for growth of physician unions. Don't call me a conformist, says the Hells Angels. Okay, conformity redux. So minions, I call them minions of hospitalists, should they unionize? We're mostly employees now, about 2/3, and there's this, I mentioned this widgetization of medicine. So the bad part about widgetization is that we lose our autonomy. We're no longer humans, we're no longer individuals, we're suddenly just these faceless, white-coated, bureaucrats, essentially, and we might lose our creativity, right? But in some ways that might be a good thing, right? Because my creativity is another doctor's low quality, right? If I vary from the guideline or vary from the norm, some widgetization is probably good, right? So, the airlines or the anesthesiologists have widgetized what they do, and we're always compared to the airline industry in terms of safety and quality, and we have essentially done a poor job of that. But so that's one way in which probably this corporatization, I'm trying to be optimistic here, maybe for the good. Okay, so Civil Discourse 1, collective bargaining. So these ancient photographs are from Cambridge Hospital circa, 1999 or 2000, so not that long ago. On the right, you see, that's me without the beard, about probably 30 pounds later, and Sonia Razminski, who's now a psychiatrist and living in Irvine, California, and that guy in the back is John O'Brien. He was the CEO of Cambridge, what was then Cambridge Hospital, became Cambridge Health Alliance, in the great days of the free care pool in Massachusetts. So Cambridge Hospital made money on the fact that it did disproportionate share of underserved care. That is, all the hospitals in Massachusetts paid a tax into a common pool, and Boston Medical Center and Cambridge would actually profit from that pool because they were doing all of this free care. We boasted that we had 75% of uninsured individuals in Cambridge had their own primary care doctor, and we could get the medications. We could literally write prescriptions, and they could go to the free care pharmacy and get their meds. All of that has changed, needless to say, under difficult economic conditions, and then the Massachusetts healthcare reform. I'm going to share with you now some what I call fundamental questions and how I approach my bloggery. So what pisses me off, right? So I've mentioned this thing about waiting. It's just something that personally drives me crazy because I think that I guess it's because I've been involved with care of loved ones and the endless waiting. And so now being on the inside, you get some insight into why things go so slowly. So explaining that at the very least to patients is something that I think they deserve, right? It's like, why do you have to wait so long? Jargon is something that drives me nuts. So I was a resident. I loved learning the language, right, about the reticuloendothelial system and how we, value-based purchasing, and what the heck does that mean? So I believe very strongly that, like, I owe it to my readers to explain sort of what those terms mean, to demystify it, essentially, right? So it certainly isn't rocket science. I mean, we like to pretend that it is, and I do understand the value of the language and learning the language. So it is important for your development, but I encourage you to remember your humanity. That's my plea today. Remember your humanity. De-emphasize some of the jargon when you're talking to patients, and it's hard because we all fall into the trap. And then probably my biggest peeve, two biggest peeves, shoddy communication and lack of empathy. So we forget. It's easy in the workaday world of training or even of practice, once you're out of training, it's part of that professionalization process. And that taps into cynicism, the hidden curriculum, and burnout, all the things that we heard about yesterday in yesterday's keynote. So my other message for graduates, for my residents, but also I got to give a commencement speech last week, but I talk about engagement. So this is for any learner at any stage. This is for adults, this is for kids, this is for graduate medical education. Engage with your patients, right? Don't forget that it's really about the patients. Engage with your systems. And you don't have to do all of these, but what are the ones that fire you up? Are you passionate about fixing the broken system? Are you passionate about teaching? Are you passionate about collectivism, about collective action and community-based practice or community resources? So I know I'm preaching to the choir here, and so I had to figure out the numbers a little bit. There's 13,000 CIR members, and that's out of 111,000 residents and fellows in the U.S. So you're not quite 12%, but that's a significant number. I mean, 12%. So you guys are really the tip of the iceberg, the point of the spear, whatever sort of mixed simile you want to use. you've got to stay engaged. You're here because you're engaged, so I don't need to tell you this, but you need to kind of share that passion with your colleagues back at home, with your patients, your families, et cetera. So, and then there's this other part of the title, pulling back the curtain. So I've used that in a blog post before, and I'm going to just tell you a story of advocacy, and then I'm going to run through my questions, and I'll take your questions, my fundamental questions. But this is an example. So I live in Oklahoma. I showed you that little red state right in the middle, and our governor is one of the, gosh, I don't know, 16 that said, absolutely, no way, we're not expanding Medicaid. And there's no logic to it, right? So she says, we're not accepting Medicaid, we're not going to do anything that's Obamacare. Because, understandably, the polling shows that Obamacare is hugely unpopular in Oklahoma, mostly because it has the name Obama attached to it, but secondarily because people are deeply suspicious of the federal government. And this goes back a long ways. This goes back to mineral rights and oil taxes and things like that. I've never lived in a state with oil. It's a fascinating thing. So I used my blog, and I wrote an open letter to Governor Fallin, and I'm just going to read you an excerpt of it. Dear Governor Fallin, I'm extremely disappointed. And meanwhile, I sent this to the newspaper, and I faxed it to her office. I didn't get a response. I'm extremely disappointed with the decision declining Oklahoma's participation in the expansion of Medicaid under Obamacare. As a practicing physician and medical educator, I see the impact of uninsurance on low-income, chronically ill Oklahomans every day. Options for these folks are few. Since they aren't moneyed and struggle to get by in every sense, they aren't well represented at the ballot box. The decision not to participate in a broadening of the safety net is morally, financially, and medically wrong. The majority of those earning between 133 to 400% of the federal poverty level are working without any safety net. They constitute the working poor. They are not, as some suggest, freeloaders. Quite simply, those with Medicaid attain better health. The data proves it. Your alternative plan of doing more of the same strikes me as both mean-spirited and inhumane to your fellow Oklahomans, whether they voted for you or not. Please reconsider this misguided decision. We taxpayers want our federal dollars coming back to help Oklahomans, not going only to more benevolent states. So I sent that off a little. I wrote it. I felt pretty good about it. I sent it off, and I shared it with some friends or people who read the blog, and they kind of cringed and they said, mean-spirited and inhumane, And keep in mind, I said your plan, your decision is mean-spirited and inhumane. I didn't call her mean-spirited and inhumane, but nevertheless, people doing a quick read of the letter think I'm calling the governor mean-spirited and inhumane. And we talk about civil discourse, right? Having a seat at the table, conformity. If I come in with spiked hair and 6 earrings, I'm probably not even going to get invited to the table, right? So there's a certain amount of respect for authority I need to show in order to get invited to the table. And working in this civil discourse type of a thing, civil discourse in terms of trying to promote an agenda of inclusiveness. So I'm going to close here in a whirlwind and take questions, but I'm going to tell you about medical secrets, and this is this idea of transparency in medicine. So make a commitment to find out or tell, okay? And I don't mean really like confidential secrets. I certainly don't mean PHI, protected health information, but what I mean is demystification of medicine. I mean, get out there and talk about what you do and what you're passionate about and explain it to people in a way that they can understand, and show me the monkey, says Curious George. So here are some questions that I think about that I would encourage you to think about. Of course, you have your own list of questions. So I've harped on this long enough. Why do patients wait so goddamn long, okay? How much is it going to cost, for heaven's sake? We have no idea, right? So the patient says to you, well, doctor, how much is this going to cost? Well, it makes a huge difference if they don't have insurance or if they do have insurance. So if they have insurance, whether they care, nobody cares what it costs. So this is from last week's New York Times. You guys saw that the Medicare released the cost data on how much hospitals charge. And this was, this New Jersey hospital that had these highest charges in the region. I see some cheers out there. And then yesterday, some of you got to hear from Neil Shah, right? So Neil started this 501c3 called Cost of Care, and it has a blog. How much is it going to cost? Point being, none of us know how much anything costs. But this attempt at transparency, we've got to be better at understanding. I mean, and the Stephen Brill thing in Time Magazine, right, was all about the charge master. How hospitals have this ridiculous way of charging, and of course, it's fantasy prices, right? Because insurers negotiate rates, and Medicare is only going to pay the Medicare standard, but yet we are part of the system by not asking more definitively or demanding, for price transparency. And this is the way. Again, it's not so much about. I mean, it is about controlling costs, right? We got to bend the cost curve, but it's also about transparency. It's also about letting, if we're really going to inform consumers, if we're going to inform ourselves about being better patients and better doctors, I think it's part of the equation. Who do I work for? Right? I work for the patients, right? But now I'm an employee, right? I work for a hospital or I work for a physician group, and it's not always clear who you work for, right? There's all these dual and triple loyalties. You know, I'm a behavioralist and I work at Guantanamo. Who do I work for there? Do I work for the patients there? That's an extreme example. But so an easy example is utilization review. So they come by on rounds, or you meet with the case manager and they say, Mrs. Jones has, you know, routine pneumonia. She's been here for 4 days. You know, she's exceeded her DRG limit. How are you going to get Mrs. Jones out of here? Right? That's an easy example. Well, it's like, you know, screw you. I'm working for Mrs. Jones. I don't think she can walk yet, and she's still on oxygen. Now, we're not sending her out. Okay, but hard examples. So I'm in a department. My chairman tells me, he says, guys, we've invested in, now I'm in a small internal medicine department, so there's some neurology in our department. So he says, you've got to refer to our neurologist. Even though our neurologist is so overbooked, I can't get a patient in to see him for 2 months sometimes, and the guy down the street who does a good job and communicates with me really well, even better than the guy who's inside my own system, so I'm under these kind of orders to, you know, refer to the people in my network. So I want to do what's best for the patient, but who am I working for? Am I working for my chairman? Am I working for, you know, the university? Am I working for the patient? How will I make an impact? You know, you guys in this room are not clock punchers. You guys are going to make an impact. You're already making an impact just because you're here, but what's your passion and what are you going to do to make a difference? So are you going to, you know, become communicators, writers? Are you going to become medical directors? Are you going to become, you know, healthcare for the homeless? Are you going to do it in your day job? Are you going to do it in your writing, your spare time, your advocacy, your civil commitments, your volunteerism? How are you going to do it? Again, what is your passion? It's asking the same thing a million different ways. How do I do the right thing? And the only reason I put that in here, it's not so self-evident, right? I mean, there are so many things that can push you away from doing the right thing, right? So there's the hidden curriculum, right? So we can make fun of patients or berate patients that annoy us or challenge us or push our buttons or have borderline personalities or who have substance abuse and want to get narcotics from us. How do you do the right thing? How do you stay focused on why you went into medicine in the first place? And again, these are some of the questions that were addressed yesterday, but there are so many countervailing forces. You can't even know you're doing the right thing. You think you're doing the right thing, and it turns out the incentives are misaligned, and you wind up doing the wrong thing, right? You want to use the best drug, but the best drug turns out to be the most expensive. So what is the right thing? And so it's actually not easy to know what the right thing is. What do I do with errors, right? We have to be responsible in how we report these things. And your institution, if you work for an institution or you work for, if you're an employed physician, you're going to get all kinds of rules and regulations about transparency and honesty. So I would encourage you to, you know, figure out for yourself how you want to deal with errors. And don't assume it's because you're not making errors and it's the other guy who's making errors, right? Because we all make errors, or we all make errors of omission or commission. What am I after? So somebody crystallized this for me very well with the 3 Ps. Am I after prestige, possessions, i.e. money, or purpose? And when you really boil it down, and any of those answers is okay. I mean, you can be motivated by money. I mean, it's scary to say that in a room of CIR folks, but money is important, right? You have loans to pay, you have families to feed, and that might be your ultimate goal. I doubt very much you're here because money is your goal, but that could be. Prestige or power. I mean, some people, so I've had to wrestle with this. And, you know, I was a house staff leader, and I was a chief resident, and I'm a faculty member, and I'm a program director, so I have these leadership tendencies. And so in my new job in Oklahoma, I recently was asked to become a chief quality officer at one of the hospitals that our residents rotate through. And I was really shaken by it. I was flattered. Wow, a C title, C-suite, you know, chief quality officer. And I really struggled. And my wife was like, yeah, you got to do that. You know, build your career. This is going to be great. And you're, you know, and I wrestled with it for about 2 weeks. And it did align with my goal. Like, I want to be a leader, but it really was not my passion or purpose. I'm definitely for quality, don't get me wrong. I think it's important, and I think we have to, but it's really hard quality. It's really quantitative, and a lot of it involves being a cheerleader and a rallier and herding cats a little bit. And that aspect of it I find really challenging and really emotionally difficult, and the kind of energy that I don't have or want to spend. And so I was able to step back and say, is this my higher purpose? And I realized where I am in life, it really isn't. And so I said no, and I think they were a little bit flabbergasted. But so think about that for you. What's the most important thing? Is it the position? Is it the possessions? Or is it the purpose? And I'm going to guess for the vast majority of you in this room, it's the purpose. And so if you can align those things, I mean, if you can get a job that pays well, but it aligns with your purpose, so much the better, right? I mean, that's one of the great things about being a physician. You're never going to starve. Will I stay true to myself? You know, again, I've asked this 3 or 4 other different ways, so I'm not going to belabor it. Why'd you go into medicine? What gives you meaning? You know, how do you avoid the pitfalls of cynicism? And then, am I of the system or am I outside the system? So these are strange pictures, but the idea, are you all in? Are you into the system, the poker chips, or do you have your toe in the water or toe coming out of the water? That is, at every level, when I was starting medical school, I was ready to bail right when I started and start an entrepreneurial thing with a friend of mine. But I was glad I went to med school. But when I was in med school, it sort of consumed my passions and my creativity for a while. I think medical school and the educational process really does make you into these sort of conforming blocks. And, you know, but I've always managed to at least keep that toe in the water of the other world. And I've come out the other end, and here I am talking to you guys, and I have this blog, and people read it, and it's very satisfying. And so I have somehow been able to keep that part of myself going and whole. And so I would encourage you, whatever, again, same type of thing, whatever gives you meaning or passion, stick with it. Even though there are times during residency you're thinking, it's beating the hell out of me. And then I guess my last one for this talk, and there could be easily dozens more of these questions. Are you an individual or a home? This picture is supposed to represent the patient-centered medical home. Quick show of hands, how many of you get training or work in a patient-centered medical home? Not very many. How many are in an accountable care organized system? Wow, okay. So these are concepts, if you're not familiar with, or if you haven't heard them ad nauseum, get familiar, because as you get out of residency, you are going to need to know what a patient-centered medical home is or accountable care models, because this is where healthcare is going. This is really simple. Accountable care is managed care by another name, but the bottom line of it is that the good part of it is it's no longer fee-for-service. The idea is we're going to pay money to keep people healthy instead of paying them for doing more procedures. Thank you. This is a picture of the praying hands at Oral Roberts University. So pray for me. I pray for you. I pray for some order as healthcare continues to literally be in a tornado-type force as change is about. So you guys are really going to be the leaders of this upcoming generation. And my last plug is any of you that want to tackle this mission of social justice and healthcare performance improvement in Oklahoma, I welcome your calls and emails, and please come. So thank you very much.